This is part one of the inflammation lecture. The inflammation lecture will cover acute inflammation in part one, and then part two will look at chronic inflammation and systemic manifestations, which include fever. Inflammation is a series of responses that are due to cellular injury or infection with a purpose of minimizing or alleviating the effects of injury, removing the damaged tissue, and promoting the growth of new tissue. So based on that definition alone, you should view inflammation as a positive process, a good process for our body. It is actually designed to address injury and improve the status of the cells and the tissues to try and bring things back to homeostasis or to normal. So oftentimes we think of inflammation as something negative. We're taking anti-inflammatories to reduce that inflammation. In general, that's looking at reducing the effects of chronic inflammation or a more prolonged or more severe inflammatory response in the acute phase. But in general, I want you to think of inflammation as a good process, something that is a normal and natural process for dealing with cell injury. Things that can cause inflammation can range from all sorts of trauma, injuries, infections, chemicals, lack of oxygen, so hypoxia. Many different things can cause inflammation. So it's anything that injures our cells. The cells of the immune system are important to know. This is a review slide. It's my hope that you already are familiar with these. You should know our granular or granulocytes, the basophils, neutrophils, eosinophils, and then the agranular white blood cells, the monocytes and lymphocytes. If you'll notice, I've got a very basic function for these cells down here in terms including platelets, the cell adhesion molecules, and endothelial cells. The endothelial cells being the cells that line the walls of the blood vessel. They're going to be real important not only in our immune response, but we'll look at these endothelial cells again when we get to the cardiovascular chapter. So if you're not familiar with this, some of this is covered in the beginning of the chapter in a review, or go back to your A&P book. I won't necessarily test on this, although it would be important for you to understand some of their basic roles within the inflammation process, particularly with the neutrophils, which are our first responders as far as the white blood cells go. Also for review should be the process of phagocytosis. So I've listed the steps for you here, and I also have an image for you. This image isn't from your book, it's actually from the A&P book here that we use at the college. So if you're not familiar with this, you didn't take your A&P 2 here, you might spend a little time just looking through the process, this image, and then back to the steps in phagocytosis. This would be testable material because phagocytosis is a major process in the inflammation process. So inflammation, as I said in the beginning, it can be divided into two phases: acute, which can last anywhere from just a few minutes to days, and chronic, which lasts from days for years. Some people suffer with chronic inflammation throughout their lives. Usually not at birth, but certainly after the point of injury. Sometimes acute inflammation does not resolve itself. And I put a note that these forms overlap. Acute can become chronic. Once it becomes chronic, the acute phase is ended. However, chronic can also flare up and go back into an acute phase through any number of factors: changes in immune system responses, new stimuli. Number of things can lead chronic to go back to acute, and then again maybe not fully resolve itself and then go back into a chronic phase. Acute inflammation has a rapid onset. It's finite, like I said. It usually lasts for just a few hours, few days, and then it's over. By over, it may be completely healed and resolved, or it may actually go to chronic, or there may be scar tissue. There's a number of things that can happen, but the acute phase itself is finite. It ends. It tends to be localized, so we don't see the inflammation to be a body-wide issue. Now, it can have body-wide or systemic effects, but it is not, in and of itself, the area of injury is where the inflammation is occurring. It can be very intense. Acute inflammation is often actually more severe than chronic, but it may not be as annoyingly long-term. That chronic can be annoying and even lead to dysfunction over a long term, but I wouldn't call it intense. Acute inflammation involves granulocytes. It actually involves all white blood cells, but it specifically involves the granulocytes. You will not see very much granulocyte involvement at all in a chronic, and in fact, the only white granulocytes that may be involved in chronic are those that are left over from the acute response. And then they produce exudate, and we'll look at what we mean by exudate, and the fluids, the substances that are produced as a result of inflammation are all part of acute inflammation. There are some cardinal or basic signs of acute inflammation. The first four here: rubor, tumor, calor, dolor, or redness, swelling, heat, pain. These terms may be starting to be a little outdated. I'm hearing clinicians say they don't use those terms as much anymore, and they're sticking with redness or arrhythmia, swelling, heat, and pain. But I want you to be familiar with both terms. You might work with an older clinician who uses those terms. So these four signs, cardinal or distinct signs that are part of acute inflammation, are all as a result of the chemical mediators and white blood cell interaction that come to the area, cause it to swell. Chemical mediators will lead to heat, pain, and that redness that you see. You can see it if the inflammation is external. If it's internal, you'd have to obviously surgically go in to be able to see it. And loss of function is not necessarily a cardinal sign, but really something that often occurs. The area that is inflamed cannot function correctly while it is undergoing this process. Systemic signs of acute inflammation are things that happen body-wide. As I mentioned previously, the inflammation itself is localized, but the effects can have systemic manifestations. You can have fever, that's a body-wide issue, and malaise refers to that sense or feeling of weakness, fatigue, achy all over, just feeling miserable. That can often occur as a result of an acute inflammation. Acute inflammation occurs in two phases. There's going to be a vascular and a cellular phase. So looking at the vascular phase, there's two points to look at here. One depends upon what's causing the injury in the first place. So if the injury is actual damage to blood vessels, a cut, a tear, some kind of impact that crushes or damages blood vessels, there will be some momentary constriction of the small blood vessels in the area. That's to prevent blood loss, but it's short term. It's going to be followed within a few minutes by rapid dilation or vasodilation of the arterioles and venules that supply that area. The reason for the dilation is once the injury has occurred, we've kind of prevented some blood loss. There's chemicals that are being sent through the body saying how these cells are damaged, these vessel walls are damaged, and that will initiate the need for all of those different white blood cells and chemicals mediators to come to that area to help repair that tissue. So you must now vasodilate in order to allow the blood to flow to get to the area where the damage has occurred. So if you've ever had a cut and you thought, oh, that wasn't so bad, I'm not bleeding, and I don't even need a Band-Aid, and then all of a sudden a few minutes later you have blood everywhere, and you're like, how did that happen? That was this vascular or hemodynamic response. Now, that's just an image showing the vasoconstriction followed by vasodilation. The response can actually follow one of three patterns. The immediate transient response is usually something that occurs and lasts only for about 15 to 30 minutes. It's minor injuries, and actually the venules, the small veins, are most involved in this vascular response. Immediate sustained response is definitely more serious injury, much more long-term, and it involves all blood vessels, arterioles, capillaries, and the venules will be involved in this response. Delayed hemodynamic response occurs when the injury doesn't have immediate effects, but rather takes some time before the damage to the tissue occurs. That's usually from some sort of radiation. And again, I list sunburn or radiation, but sunburn is a UV. It is a radiation effect as well. That's usually where you see the delayed hemodynamic response. There may be some chemicals that may cause that, some toxins in the blood from a bacteria, for instance, that may cause that, but primarily it's sunburn, it's radiation exposure. The cellular phase is going to involve really the white blood cells. So we have really chemical mediators acting upon the cell, the vessel walls, and we have what are referred to as cell adhesion molecules, or CAMs, that are being activated in order to ensure that as the white blood cells flow to the area, they don't flow past, but they actually adhere to the vessel wall and then can move out of the cell. Here's an image to kind of show you the sequence of events and where those CAMs and the chemical mediators fill in. So with rolling, the neutrophil passes along the vessel wall. It'll loosely attach and release prior to encountering the correct chemical. So they just kind of roll it. You kind of get a little bit of this image that, like, well, they're rolling along, it's sort of attached, but then it came off. And so in that rolling phase, that actual kind of adhering, not adhering, until it finds the right chemical mediator or chemo attractant to attach to, helps to actually increase the thickness or viscosity of the blood. It slows the flow a little bit, and then it allows that cells to start to, it kind of allows enough time actually for the cell adhesion molecules, the CAMs, in order to be activated. So rolling is a separate phase from activation, but they tend to be happening at the same time. The effect of rolling leads to the activation of the CAMs and other chemicals in order to allow the next phase, what we refer to as rest and adhesion or margination. And in the image here, you'll see that the white blood cells in this phase actually start to cling to the walls of the vessel. Once they've clung firmly to it, they will then migrate out. That's, you can see them moving here. They call it transmigration or migration, emigration. All of those terms are correct. And they almost form like a little amoeba-like action where they move through the openings between the endothelial cells of the vessel wall, and they can then move out into the target areas. There is some red blood cells that can leak out during this process, but for the most part, the red blood cells do manage to remain within the vessel. So there may be a little bit of blood loss, but not much. But this process allows the white blood cells to get to the area, and then, if you recall, in the image of the phagocytosis, chemotaxis can take place, and we now can engulf. Chemotaxis will take place, and phagocytosis will follow, and will engulf and destroy the pathogen. In this case, our image is a bacteria. So the steps here are kind of stretched out a little bit to kind of show this process of what's going on here. I mentioned a number of times already that there are chemical mediators. There's lots of chemical mediators covered in this chapter. So I've put everything that you need to know about the chemical mediators in this PowerPoint presentation. So although the book goes into a lot more detail, what you're required to know are what's in these slides. So the purpose of chemical mediators is listed here. They enhance the inflammatory response by doing all of these things. Now, not each one does each thing, but the combination of these chemical mediators takes care of these issues. Increase the permeability of the capillary so that those white blood cells can move out, just as I showed you there. Helps with the vasodilation process. Has a chemotaxis effect. Chemicals pull white blood cells to the area, stimulate that process for phagocytosis to take place. They cause pain, which calls attention to the problem. So this is a picture from your book. Again, it gets a little bit overwhelming, but I have this picture here for the sole purpose to say that there are two different categories of chemical mediators. Those that are derived from what we refer to as plasma derived. The liver is involved in that. So these things that are listed here, and the main one that you need to know for this one, the complement, the fibrin, and the kinin or bradykinin. So in the next slides we'll give you the details on that. But those are ones that are derived from the plasma within the blood by the liver. Then you have cell-derived mediators. Cell-derived mediators are all of those white blood cells, platelets, mast cells that I had actually showed you in the beginning, and what's being produced there. Now again, you do not have to know the full of this slide and be able to identify each thing specifically. Rather, just recognize cell-derived and plasma-derived, two different categories. So in the plasma-derived chemical mediators, you have the kinin or bradykinin, the clotting, and the complement. And hopefully you've heard of complement before. You may have had all of these in your AMP2 experience, but hopefully at least complement. That cascade of plasma proteins made by the liver, they promote a number of different responses in the immune system, including activation of antibodies. So very important in our full immune response, and actually a component of the acute inflammation response. So everything you need to know about those is right there. And again, these are the plasma derived. Here are your cell derived. You have the histamine, the serotonin. They have some similar actions, so there's not a huge difference between the two. So whatever actions that histamine has, serotonin actually has the same actions with regards to acute inflammation. There are other responsibilities of serotonin elsewhere, but I'm looking only at its role here in the acute inflammatory response. So histamine's pretty pretty powerful vasodilator. So it really is very helpful. It's one of your earliest chemicals involved in an acute inflammatory response. You've got your neutrophils acting rapidly. Histamine's being produced very early on as well. Then you have what are called the arachidonic acid metabolites. I don't need you to necessarily have that term. I'm just saying under that category there are two things that you see a lot. Prostaglandins, they are really an induction molecule for inflammation. They really promote that action. They enhance the effects of the histamine. They are actually lead to some vasoconstriction, however, by promoting the platelet plugs that can form, that when I say aggregation, that cluster of platelets to make like a platelet plug, preventing blood loss. Leukotrienes also function similar to your histamine. They're involved in the cell adhesion, so that we're helping the cells to attach, and their role in bronchial asthma and anaphylaxis is more in another chapter. I just put it in there as a reminder. So those are your cell-derived, and then your final cell-derived one is the nitric oxide. It is a very powerful vasodilator. We're going to look at nitric oxide's role in the cardiovascular system as well, because it is primarily reduced from the endothelial cells that line the vessel walls. All right, and then this slide gives you a summary of the acute inflammation process. I encourage you to check the video is working, so I won't click from it here, but it does a nice little overview. It's not very long at all, just a few minutes, but it gives a good overview of the inflammation process and the role of the white blood cells moving into the area. So I encourage you to go ahead and take a look at that. And, the local manifestations for the acute inflammatory response, I'd mentioned in the beginning that one of the things that occurs is the production of exudates. Exudates are fluids that are produced, or substances that are produced from the cells that function to aid in the location and typing of the injury. And by typing of the injury, I mean that they can help to determine what actual kind of injury, what's really going on, can determine what kind of exudate is there. So again, its purpose is to secrete substances, fluids that function to aid in both the location and typing of the injury. It actually, in many cases, localizes the injury, prevents it from spreading further. So there are 6 different types of exudate that are produced. These are, again, fluids produced. Serous exudates come primarily from serous fluids or from the plasma. It's watery, clear substances. It's often found in blisters. You see that in nasal allergies when your nose is running a lot. They're probably less severe. Again, it's that kind of watery fluid. If you have a little blister from an injury, you may see the watery fluid that's released. That's serous exudate. Fibrinous exudate is the thickest type. It's very thick, sticky from all of the fibrinogen fibers. It looks kind of similar to a blood clot, although it won't be red like a blood clot, but it'll have that sort of stickiness of the blood clot. It walls off, localizes the problem, and if it lingers, it'll lead to scar tissue. It's particularly problematic if it occurs in joints, and so it is associated with rheumatoid arthritis. It also is involved in appendicitis or in rheumatic fever, and rheumatic fever is damage to the heart due to infection, and we'll talk strep infections, and we'll talk more about rheumatic fever in the cardiovascular chapter. Membranous exudate develops primarily on mucous membranes, and what happens is the mucus accumulates with the fluids that are being released from the cells of the acute inflammation to form a very thick or dense membrane. So it has a lot of cell debris, waste products intertwined in this tissue. It really can wall off an area and be very problematic. If it occurs in the mouth or on the tongue, it can be what occurs in like a yeast infection, like thrush. In diphtheria, it forms in the trachea and upper respiratory tract, and actually can impede the movement of air in, and can actually and carbon dioxide out, so it impedes gas exchange. It also can form in the colon as a response to membranous colitis, in which case it blocks the flow of substances through the colon. Purulent exudate is pus. That's just plain and simple. It's that thick yellowy substance that's often produced with acute inflammation. You can see it in if you have abscesses that form, they will be within the abscess. Sometimes they have to be surgically removed. There tends to be a high level of bacteria enclosed within the abscess or within the purulent exudate. So it's thick, but not as thick as the fibrinous, and it tends to be more of a yellowy because of all of the different debris, a lot of proteins, parts of white blood cells within that purulent exudate. Hemorrhagic exudate is usually as a result of surgery. It's probably the most severe. It contains blood within its fluid. There is one exception, though. A blood blister, if you've read a blood blister, is a result of a hemorrhagic exudate, and therefore that's not necessarily all that severe. But the majority of it is going to be internal. And then serosanguinous exudate is actually a combination of hemorrhagic and serous. And so it's really something that is found in wounds, abrasions, and it's actually common after surgery. So serosanguinous is that combination of serous and hemorrhagic. I've already mentioned the abscesses. That's that localized area of inflammation that contains purulent exudate. And ulcerations are a site of inflammation where the epithelial surface has become necrotic. So in an ulceration, we have dead tissue. Abscess is not dead tissue. Ulceration would be a dead tissue. And then finally, the resolution. So what happens with acute inflammation? The resolution, or how does it resolve itself? Because I said it's finite, it will end. The resolution may be that it has a resolution. It is returned to normal. So one thing that can happen with an acute inflammation response is it can run its course and the tissue can be restored and you're back to normal and you have no real remnants of it. The second thing that can happen is it can form into chronic inflammation, and so that's the second lecture. And then there also can be some scarring and fibrosis that can occur if there's a substantial injury. It may be that the tissue cannot fully regenerate itself, or in fact the tissue itself is non-regenerating. So scarring and fibrosis occurs, for instance, in damage to muscle tissue. Muscle tissue does not regenerate. So that's the process of acute inflammation. The second lecture then will go into chronic inflammation.